Dennis and Stephen, really wonderful material tonight. What a pleasure it is to be with you. Really great material, and what a wonderful case to finish with. A real challenging case, a case that really makes us all think about doing implants at all because of the challenges involved in the aesthetic zone and that relationship between the bone, the teeth, and of course the lips and the face. And that young lady at the end having to go through all those procedures to reconstitute the lost soft tissue complex to make it aesthetic and aesthetically pleasing for a young lady. We always look at complications and how we manage it, and David and I always think about the interface, and you guys really described many of those interfaces this evening. And we're going to really discuss that as well from our perspective and how we look at the exchange of the interdisciplinary treatment, how we analyze the bone, and then how we handle the soft tissue, and how we kind of fix the problems that we sometimes see in these cases. And obviously a lot of these cases we just don't see in our practices. And a case like you just showed, I'm sure many people have these problems. They've never seen a lecture like that before or a presentation like that before. And you look at some of the newsletters on Dental XP, a lot of these that you can see above you is that you have an issue with really complications with many different situations, and we're sometimes asked to manage those complications in different ways. So if we're going to go ahead and manage complications, let's start with a case such as this one. What we're really doing is really focusing on this problem right here in the maxillary right central incisor. It's a case that has been recently treated. The patient unfortunately has had some recession on the left central incisor and left lateral incisor, and we have an apical lesion endodontically that has been treated several times and is failing once again. And an implant was placed, and one of the problems that we see immediately when the implant was inserted is the location of the implant in terms of how close it is to the lateral incisor, number one. Number two, for David and I, is, this implant really, from the onset, we have a soft tissue discrepancy between the right side and the left side. And therefore, we really have to consider this situation, the labial soft tissue recession, as well as the interdental recession that's already present before we even start in this situation. So when we go ahead and take a look, at a failing tooth and we're going to replace it, we don't just think about placing an implant. We really start thinking about the soft tissue as a curtain for the final aesthetic result. And obviously for a single tooth central incisor case, we really have to consider that from the onset. Where is the bone in this area, the interdental area, the separation of the implant from the lateral incisor, and then of course the soft tissue on the labial aspect, even to begin with, is already a concern for us. So we're going to go ahead in this case, and the implant was placed by another dentist and sent to our office. The patient was quite upset. Obviously recession on the facial aspect, but even more dramatically on the lateral incisor now, on a tooth that they had no intention of restoring. This is a patient that already was upset that they were losing the left central incisor. Now they're concerned about what they're going to do about the left lateral incisor, and we have also even lost more of the interdental papilla. This became a very big issue for us, and how does our team actually manage these aesthetic abnormalities? And of course, one of the first things that we've looked at, has been mentioned earlier, is where is the bone on the mesial of the lateral incisor? And how close is this implant to that lateral incisor? And how stable is that lateral incisor? And we have a few options. I mean, obviously, one of the options is to, as was shown beautifully by Dennis and Stephen, is to erupt the lateral incisor, something we've been doing for many years, to bring down the soft tissue on the labial aspect and the interdental aspect. And that's something that I actually spoke to the patient about. And David recalls the patient was very upset. He said he really didn't want to go through restoring that lateral incisor again, not only from the cost, but for the chance that that lateral incisor may become too mobile from the tooth movement. We wanted another option to reconstitute this. What we decided to do is to look at cases differently, not only for osseointegration, but obviously from the onset to avoid these problems of compromised aesthetics. Now what we did is brought the patient back in and went down to the implant. One of the interesting things in this case was that if you see here in the labial aspect, we actually have good bone. Bone here is actually quite good, David. We have 2 millimeters in front of the implant. We're about 1.5 millimeters from the lateral incisor, so although it looked quite close, I think we're okay here. And then over here, which is really quite interesting because Dennis had just shown a dermal graft. This was actually a acellular dermal graft that was placed by the previous surgeon. This is at about 4 months after the first surgery, and you can clearly see that this graft has been integrated, which is quite interesting. We don't always get the chance to re-enter these areas. So it's obvious that these types of tissue grafts do integrate quite well. They become functional matrices, and they do become bound down functional tissue. So something that I think is very, very significant in the way that we look at these types of tissue grafts in the future. What I decided to do in this case, as I spoke to David, is we took an impression of the implant, and I went ahead and I raised the flap, making certain to incorporate the interdental papilla here, because our intention was to use autogenous soft tissue to completely submerge this implant and to try to cover the defect on the facial of the lateral incisor and the mesial of the lateral papilla. So surgical reentry was performed, an impression taken for second stage uncovering, and soft tissue recovery procedure, just like you've seen previously by Dennis and Stephen, was performed. You can see at the time of surgery we were able to completely cover the lateral facial dehiscence as well as the interproximal area, and our hope was obviously that it would heal quite well. And what you see here is day 0 and day 60, our ability to reconstitute this very, very important area. Now, at approximately 2 months, when I looked at David, I said, you know, it's obviously something that we could probably pursue without having to redo this lateral crown. We can treat this as a single central, and I was a bit concerned about the second stage uncovering. So what we decided to do is, rather than take the risk of a reentry procedure, is a simple tissue punch recovery of that implant, making sure that we leave the thickness of tissue that we were able to recreate on the facial of the lateral and the mesial, and then place the abutment that was created from David's impression at the time of surgery directly onto the implant through that tissue punch exposure. And this really allows us to immediately place the abutment, gives us access to the area, and allows us to start shaping the tissue with the temporary restoration. Again, submergence profile, very big issue, just mentioned by Stephen. See that what we were able to do here is take the lateral incisor and really utilize the soft tissue graft to not only to cover the lateral incisor and interdental tissue, but also the lost tissue on the facial of the healing abutment. This is actually an interesting case because when it was first sent to us, case sent to David, was asked for us to just simply attempt to restore this case with a single implant and artificial gingiva. And what we decided instead to do was to try to either do this just with soft tissue, or if we had to do some forced eruption to reconstitute some of that papilla, we would. But we were able to do this instead just with autogenous soft tissue, and I think in many cases, recovery of aesthetics really requires not only bone manipulation, but really soft tissue management, the ability for surgeons doing implant dentistry to understand the importance of soft tissue recovery procedures, as simply beautifully highlighted by Dennis and Stephen, utilizing a layered approach or multiple surgeries to try to reconstitute that lost tissue. Of course, always better for us to understand that it's better not to lose the tissue from the beginning and to properly analyze the case with bone sounding procedures. So for us, it's all about the interface, where and how we develop that interface, whether it be a single tooth or even more importantly, multiple adjacent teeth, as was just shown, and how difficult that becomes. And of course, the fully edentulous patient, where we have more control over tissue dimensions as well as tooth proportions.
When you're kind of looking at this as everything else, I guess it's how you define success. And that interface really defines success for us. This looks like a pretty successful case when you evaluate it. So the first one is an attempt to be really pretty, They've characterized it pretty effectively. But if you really start to look at it, and you start to look at the crucial interfaces, and you go back, just look at what this looks like. So we have osseointegration, we have a functional restoration, we have pretty ceramics. It's actually on the cover of the Journal of Prosthetic Dentistry. So it really becomes an issue of what is your goal of therapy? What are you actually trying to do in this? And when we look at this, obviously we can be critical of it, but it may have satisfied the patient's goal, it may have satisfied the dentist's goal, and from our perspective, we're missing a crucial little piece of tissue. Is it really relevant? And certainly from the process of education, it is just that. So you look at that case, and you kind of evolve, and you're looking at tooth replacement, but it's not tooth replacement. It's tooth replacement and that crucial interface between the tooth and the underlying soft tissue, and quite often positioning that interface within the context of the face as it is relative to the lip. And it's one of the things that we have discussed over the years. So you've got to decide on this goal of therapy. Let's take a look at another case here. Maurice and I looked at some years back, and the issue is we've already been through bone regeneration in this. So it's a previously failed graft. There may be some residual graft there, and we still have to replace 2 teeth. How do you actually go about this? Obviously, we can go to 4 units of restorative, we can go to 6 units of restorative, 1 implant, 2 implants, as we're going to discuss with you. But the real issue is, how do we replace that restorative gingival interface? Can we actually get to the gingival aspect and recreate it totally here? I mean, is there a way that you could do this?
Well, one of the problems that we always have is when we're looking at cases is that we really have to decide on what is the best treatment plan and treatment sequence for management of this type of problem. First of all, we've seen already that the central lateral in the maxilla is a very difficult environment because of the anatomy and because of the spacing issues. Placing implants there, Henry has once talked about it being the Bermuda Triangle of implant dentistry because of the anatomical limitations. Just simply placing an implant in central lateral doesn't give enough space. One of the other problems we have is really in the lower incisor region, placing 2 implants next to one another because of the narrow ridge, and then of course because of the anatomical limitations distally. And we have some new implant components available today to treat this, utilizing 3mm or mini screws. That really doesn't solve the problem. The problem is we've already failed this patient with a graft. And now we have to come up with a solution because there's a young lady in her 30s that wants a permanent solution that not only gives her function but also aesthetics. When we take a look at these types of problems, we have to factor in that we need to reconstitute the buccolingual dimensions as well as the interproximal ones. So what we really want to achieve is not only tooth replacement with optimal aesthetics. And what we saw in the previous case, obviously this is not a case that is not functional. We have 2 implants that have osseointegrated. This was a cover article in the Journal of Prosthetic Dentistry. Beautiful ceramics, root form, and certainly nice color, but the issue is really the aesthetics of this environment. And then of course for me as a periodontist, David, I have to tell you the long-term management of this area as a cleansable area becomes quite uncomfortable for me. The implants are very close together, the tissue, the ability for us to cleanse this area, and then the fact that with a little bit of bone between the implants has a higher risk of further bone loss would be something that I would be concerned about.
So it's a potentially vulnerable area all over again.
Absolutely. I think that we have to be concerned not only with aesthetics, but long-term maintenance of this very, very critical seam. So for our group, obviously, we do concern ourselves with aesthetics, and we do want the goal of therapy to be to reconstitute the lost vertical and horizontal component of the ridge, but we want to do so in a way that would give us the best opportunity to do this, not only for the aesthetics, but also for long-term management of this periodontally. What we decided to do in this case is something that has already been shown from forced eruption, but actually rather than extruding the teeth to manipulate the attachment apparatus, we decided to actually move the lateral incisors mesially towards the midline, actually making the lateral incisors central incisors and reconstituting the ridge dimension, both horizontally and vertically, utilizing orthodontics rather than additional surgery. So as an option to surgery, we reconstituted the ridge using orthodontics. The laterals are now centrals, and we can now put small diameter implants in the lateral positions. Now, this takes this case not only from a surgical standpoint, reconstituting the ridge, David, but now it turns it from a case where we would have required 2 adjacent implants, where we would have spacing issues, to 2 single implants that were placed in the previously areas of the lateral incisors.
I think this is really what Dennis highlighted. You've got the adjacent teeth here to support the papillae, and then what you actually said is these are 2 different diseases. The interproximal and the buccal are 2 separate issues. We've really kind of eliminated the interproximal by having the adjacent tooth there. Now we're only having to deal with the buccal aspects of it. So you've got 2 implants still, but 2 separated implants, not adjacent.
What's really quite interesting here is that you remember we had a defect that was both vertical and horizontal, and without doing further surgical reentry, you were able to reconstitute the ridge and the vertical component of the papilla by moving the laterals towards the midline. And what it left behind were 2 ideal sites for implant placement. So when you move the laterals into the position of central, it leaves behind ideal placement areas for the implants that were then placed. So what we did here as a first option was utilize what we call orthodontic neogenesis, and then 2 single implants placed in the area of the laterals, avoiding this very, very difficult situation of placing 2 implants next to one another in the small diameter areas. So just one option, again, to move the laterals to the midline, creating what we now have as 2 single implants as opposed to 2 multiple adjacent implants that are really, again, fraught with problems for us as implantologists. And focusing in this area, really creating this and recreating this deficiency non-surgically using orthodontic means. And I think, again, a very, very powerful tool, something that Dennis and Stephen showed beautifully, and something that we've used in our practice for the better part of 20 years. If you take a look at a case such as this one, a real difficult environment, a patient that was sent to us as a consultation from an orthodontist. They'd been in Invisalign and blew an abscess around the left central incisor. The adjacent incisor was very mobile as well, and you can see it on the x-ray that we have bone on the right lateral incisor, but we've lost bone not only around this tooth, but also around the mesial aspect and facial aspect of the adjacent central incisor. So once again, we're going to be caught with a similar situation here, David, of having to replace 2 teeth in the mandibular incisor region, and here we have a severe labial deficiency of soft and hard tissues all the way down to the mucosa. There's no attached gingiva remaining.
Even exacerbated because you've got even less distance between the adjacent teeth to manage.
And this is crowding of the dentition. This is one of the reasons that Invisalign was utilized to try to unravel these teeth, and then they were stopped during the infectious process, and obviously we still have the crowding. So not only do we have 2 incisors, we have 2 incisors that were in an otherwise crowded dentition. So one of the questions that I had to ask David is, do you think we should plan this case to replace the 2 incisors with 1 incisor or with 2 incisors, giving the patient 3 incisors or 4 incisors as a final goal?
And obviously, surgically, it's much easier for us to put a single implant in. And I was contemplating doing a little bonding on the adjacent to the lateral and the central, as you can see. And the idea there would have been much simpler. The patient didn't really like these oversized teeth, so I wanted to know, could we replace 4 teeth? Not as crowded, but kind of as we had them before. So we looked at these options. I said, Maurice, we're going to put in 2 teeth. How are we going to do implants? 2 implants?
This is a challenge because obviously what's nice is doing the wax-ups from a restorative standpoint gives me a lot of information, gives David a lot of information. What we're able to do is show the patient that we would need to do either small veneers, which will be highlighted tomorrow in a webinar by Christian Coachman, and a single implant, or do 4 incisors and then have to reconstruct two very small diameter teeth. And as a surgeon, for me, David, this is a real problem. And obviously we tried to speak to the patient about this, and the patient really said he wanted a solution that would give him this result rather than the result you see on the left.
And how about that vulnerable area there between two implants?
Well, this area right here I felt was something that I couldn't achieve trying to put in two implants. So we had to come up with another option. And we just showed you one option, which was to utilize orthodontics. And what we did in this case was go ahead, remove those two teeth that we just showed you that were failing, degranulate the areas, and we utilize a combination of mineralized radiated bone graft, allograft, mixed with PRGF, and we utilized fibrin and plasma-rich growth factor. And on top of that, in order to take care of the recession defect, we did it as a layered approach, utilizing soft tissue as well. A double pedicle was also utilized to achieve primary closure. So what you're seeing is primary closure at the midline over that very wide dehiscence, that fenestration of the soft tissue. I was able to make a vertical incision here and rotate the two pedicles over the graft material to make sure that I can gain complete closure of the implant site. Now, one of the interesting things here is that David's had suggested is because we had lack of space for two implants, was to place one implant, but rather than to do one offset towards one incisor or the other, he decided to do something a little bit differently that we just recently published on, was to place the implant directly down the center of where the papilla needs to be, utilizing a concept that we just really, over the last few years, started to really utilize, which is to utilize artificial gingiva. So what we have here is the reconstituted area at uncovery. You can see we've been able to reconstitute the ridge both buccolingually. You can see a tremendous amount of horizontal keratinized gingiva now present where there was none. We got good vertical height here of the interdental papillas on the adjacent teeth. And the implant has been placed towards the lingual to allow us, as you can see, very importantly, for screw retention. And this is something that's very important. Now, David has to work out the aesthetics utilizing one implant rather than two. This is another option that we think is quite important.
So we're going through the process over here of impressions and grafting. And you'll see, when you talk about grafting, when we're talking about artificial gingiva, we tend to graft buccally, knowing we're not going to get all the way vertically. And we like to get an added bonus of soft tissue, lots of volume of soft tissue. You can see that we've deliberately placed this lingually because we know we're going to add some prosthetic phase to this, and the screw is actually going to be through the back of the papilla, and that's kind of what we're aiming at deliberately in this. Now you can see where the screw comes out between the two teeth, so you've got kind of a half a pontic on either side. And you can see on the right-hand side, where is my pointer? Oh, give me my pointer back. Oh, there it is. You can see where we've actually allowed us to build the papilla where there was no problem with screw access. So it's really given us the prosthetic ability to do these things. Now you can add that tiny little piece of papilla. The interface is going to be flattened, as we talked about. We don't even do ovate pontics in these. We try to get flat surfaces all around that are cleansable.
And David, this is something that's done with composite resin. It can be done chairside, a direct technique, rather than having to do it with porcelain, pink porcelain.
But the whole idea here from prosthetic aspect is trying to get someone to do really beautiful porcelain like this is difficult. So we tell them to idealize two teeth based on the adjacent teeth, ideal form, and we come back. If they put a little bit of pink porcelain in there, that's fine. We etch it exactly like the inside of your veneer cases. And then we add we add composite directly in the mouth onto the tooth. So it's a direct aspect. So you get a really nice, clean interface, and then you just smooth it off.
And this is something that you'll see mentioned again tomorrow evening on the webinar with Christian Coachman that will be at the same time here, Eastern Time, 7 o'clock. So the implant prosthesis must be cleansable. One of the things for the surgeons to understand is, you remember I built out that buccolingual ridge, David, and that we don't try to create an ovate pontic, but actually a flat ridge. So it's very easy to get floss underneath here or to get irrigators underneath here. It's very important that we don't have a ridge lap and this is something that is clearly cleansable for us, and we've seen it being easily maintainable over time. From an aesthetic standpoint, obviously, on insertion, you can see that this little piece of artificial composite resin for the pink interface occurs right here on a flat ridge. We have a screw retention capability, so we can always gain access to this area, and you can see again the importance for the surgeon to build out the buccolingual aspect and not to be concerned as much about the vertical aspect of the interdental papilla. So it's one implant placed down the center, biomechanically much better. Also from a aesthetic standpoint, obviously there just simply wasn't enough room. You can see clearly on the middle slide, just not enough room to place two implants. And rather than offset one implant, try to create an ovaponic, placing one implant down the center and then building up the papilla may be a very, very effective alternative option.
And really, down the center is one issue, but really what you did there for me was to put it lingual, allowing me to have all that space to play prosthetically. If you'd gone down the middle of the ridge there, we would really have been in trouble.
Well, we see two different options here that David and I want to focus on, not in just the maxillary anterior region, but the mandibular anterior region, is to deal with it by segregating the implants on the first case, placing them in the lateral position, or to do it with a single implant supporting two teeth and utilizing artificial gingiva at the midline, which is another option. And here's the final aesthetics. You can see this gentleman on a high smile line. Really looks quite good, and I think that we can be very pleased as this is an option that works quite well. And as they get older, these patients actually show the aesthetics of the lower teeth even more than the upper teeth. And this is pretty routine as they get into 60s and 70s. You'll see the upper lip start to come down and the lower lip and the lower gingiva start to show up. So 18 months post-op, you can see one of the important things that people always look at is the bone-implant interface. This is at impression time, and this is now 18 months post-op. You can see that the bone has really performed very, very well. This is a BTI implant that I inserted that's supported. This is a 3.5 millimeter implant supporting two lower incisors and has done so quite well with any problems in terms of bone loss at the crest. So the final result, again, very difficult to tell that really artificial gingiva is there, just simply there to give us that advantage of creating that interdental soft tissue.